Hi, I'm Dr. Glenn Bauman, professor in the Department of Oncology at Western University and radiation oncologist, and I'm happy to introduce practical session 2, which is looking at the integration of PSMA PET into the treatment of recurrent metastatic disease. And in this session, we'll talk a bit about a few scenarios, regional nodal recurrence, different settings of oligometastatic disease, as well as oligoprogression. So when we think about the setting of recurrent extrapelvic metastatic disease detected on PSMA PET, it's important to understand the setting in which this is occurring. Is this synchronous with the detection of with the diagnosis of the primary tumor, or is it metachronous, so it's occurred after the original tumor has been treated? What do you decide is oligometastatic disease? Is it 1 MET? Is it 3 METs? Is it 4 or 5? And how are you defining the number of METs? Are you using conventional imaging versus molecular imaging with PSMA PET, for example? And what treatment has a person received to date? Have they had systemic therapy or not had systemic therapies? Or are they hormone naive, not having had androgen deprivation therapy, versus castrate resistant, where they progressed despite prior androgen deprivation therapy? And if they are on a systemic therapy, what's the setting in which this limited volume of cancer has been detected? Is it detected as oligopersistent disease, where a large number of METs have responded and maybe there's 1 or 2 that are staying active despite systemic therapy? Or is it oligoprogressive, where number of sites of disease are controlled with whatever systemic therapy is being used, but maybe there's a few sites that are starting to progress despite that? And then thinking about recurrence, whether it's local regional, so in regional lymph nodes, versus metastatic, which would be extrapelvic, bone, or visceral or nodal disease. So we'll look at a case of a man who had localized prostate cancer, subsequent biochemical failure, and had salvage radiotherapy to the prostate bed, but then had another biochemical failure, and PSMA PET demonstrated a number of avid pelvic lymph nodes, but no extrapelvic disease. And interestingly, while most of the nodes were in typical locations in the iliac chains, there was one paravesical node which was noted, which was next to the bladder, which was a relatively atypical location. So here is the original prostate bed radiotherapy. So in men who have lower PSAs at the time of salvage or don't have risk factors for regional nodal radiation, prostate bed only salvage radiotherapy is still relatively common, but means that regional nodal volumes are not irradiated and potentially are sites that could be harboring micrometastatic disease, which then could contribute to later biochemical failure, as was the case with this gentleman. So here you can see in the center panels this perivesical node, which was identified in an atypical location, just anterior lateral to the bladder, in addition to lymph nodes higher up in the pelvis, which are seen on the flanking images. This presented a technical challenge because the perivesical node was pretty much on the edge of the prior prostate bed volume, so concerns about overlap with previous treatment to the prostate bed. So this area was treated with a very focused stereotactic approach, and then the nodal volumes that were outside of the previously treated prostate bed were somewhat larger, with elective nodal radiation of the nodal chains and then a simultaneous boost to the PET-involved nodes. And then this salvage radiotherapy given with 6 months of ADT, consistent with the STORM trial that randomized men to regional nodal radiation with boost, showing advantage over radiation targeted to the PET-identified lymph nodes alone. In this case, we have a gentleman who presents with synchronous oligometastatic disease, so locally advanced prostate cancer, PSMA PET, though demonstrating spread to a pelvic lymph node in the right external iliac chain, and a solitary metastasis in the C1 vertebral body. So in this case, given the single site of metastatic disease, we chose to move ahead with radical treatment to the prostate and regional lymph nodes, and then stereotactic radiotherapy to the single site of bone metastasis, and then also intensifying his androgen deprivation therapy with an androgen receptor pathway inhibitor, recognizing that he now has low volume metastatic disease. So this is just an example of the radiation plan treating the prostate and the involved external iliac lymph node, and then the stereotactic treatment to the involved bone at the C1 lateral process. Here a fused MRI scan showing superimposed dose distribution. So another setting here of a man with high-risk disease, so synchronous, presenting at the time of diagnosis, high-risk disease, staging PET-CT, molecular imaging T3B, N1, but now an M1 case because he had uptake within periaortic lymph nodes as high as the crura, so fairly high up in the abdomen, but not in bone, not in lymph nodes above the diaphragm. So in this case, we chose to proceed with treatment to the prostate and regional lymph nodes, and in order to manage toxicity with larger field nodal irradiation, we chose to do stereotactic radiotherapy to the involved periaortic nodes, and then intensified his hormonal therapy with an LHRH agonist, so ADT and an androgen receptor pathway inhibitor. So here we see on the left the treatment to the prostate and pelvis, and then on the middle panel and the right panel, the periaortic nodal volumes. And the far right panel is just illustrating this idea that depending on what you need the fusion for, you may accept a closer or less optimal fusion. In this case, you can see there's a very good match between the PET-CT and simulation CT in the pelvis, because we were using the PET information in the pelvis to help us delineate cancer in the prostate. But because of different positioning at the time of imaging for PET versus CT or simulation CT, the upper spine is not as well aligned, and we can see there's more of a divergence between the two volumes between the PET-CT and the simulation CT. But again, since we're using the PET primarily to identify those nodes which are involved, and we are contouring nodal volumes based more on the CT, we can accept that fusion is less optimal in the upper abdomen here, as long as it still allows us to flag which lymph nodes need to be targeted, which was the case. An example of metachronous oligometastatic disease, so a man with prior prostatectomy, prostate confined disease but with a positive margin, and a relatively low PSA at the time of relapse. So this is a man you would think would be a prime candidate for salvage prostate bed radiotherapy, but on PSMA PET was shown to have actually a nodal recurrence in an atypical spot. So this was an isolated uptake within a inguinal node just posterior to a hernia sac. So this man had had prior surgeries for hernia, and that may have altered his lymphatic drainage somewhat. So in this case, we elected not to treat the prostate bed and regional lymph nodes, but rather we used stereotactic radiotherapy to this isolated lymph node, primarily from the perspective of trying to minimize morbidity, because this man also had implanted sphincter, and we did not want to interfere with the function of that device. So with the PET information pointing to this isolated non-regional lymph node, we chose to approach this as a situation where we do stereotactic radiotherapy alone, and then adding in 6 months of ADT as well. So here we see the lesion being treated with a stereotactic dose of 30 gray and 5 fractions given every other day with 6 months of ADT, and omitting the regional nodal radiation. We will follow this man along with serial PSAs, and if it goes up again in the future, we will repeat his PSMA PET scan, and we may yet need to go back and deal with regional disease, but we will see how we fare with this treatment. So this is just showing the PET signal, but then the underlying anatomic extent of the lymph node that was treated. Oligometastasis may be a recurrent problem. So after initial treatment of oligometastatic disease, men may do well and not relapse, but men often will relapse with rising PSA again. Some men will have more extensive disease at the time of relapse, which will be better addressed through systemic therapy. But some men will have serial oligometastatic failures, in which case repeat stereotactic radiotherapy may be possible. So in this case, man had prior prostatectomy and adjuvant pelvic radiotherapy, and then his initial relapse detected on PSMA PET was in the mediastinum and a paratracheal lymph node, which was treated with stereotactic radiotherapy, and then subsequently had PSA progression about 3 years later, 2.5, 3 years later, and PSMA PET showed an abdominal lymph node, which was an isolated area of uptake. So that was treated with stereotactic radiotherapy as well. For this man, we elected to roll him on the OMPC trial, which randomizes between SBRT alone versus SBRT plus a systemic therapy with PSMA targeting radionuclide, lutetium PSMA, and he was randomized to the combination, so he went on to have lutetium and PSMA after his SBRT, so he's actually in the middle of treatment now. He's had his first cycle. And part of this larger study, which is being completed worldwide to try and determine if there's an advantage to combining a systemic radiotherapy through lutetium PSMA with SBRT. And finally, this idea of oligo-recurrent or oligo-progressive disease. Men will be on hormonal therapy as the backbone of treatment for prostate cancer once it's recurred despite local therapies, or if it's become or presents as metastatic disease. And over time, prostate cancer will become resistant to drugs that manipulate hormone levels in the body. So with simple androgen deprivation therapy with LHRH agonists alone, if there's progression, then second-line hormone therapy with an androgen receptor pathway inhibitor is usually the next line of treatment. But beyond that, you start to get into drugs like chemotherapy, treatments which tend to carry higher toxicity, or second-line ARPIs, which may be less efficacious. So there is a motivation to try and extend the duration of a systemic therapy if it's otherwise working well. The challenge can be identifying, how these men are progressing. So this is a case of a man with CRPC, so castrate-resistant prostate cancer, and from the CT scans on the left, you can see that there are a lot of sclerotic lesions in the bone, but most of these are inactive. Those have responded to treatment. They've been stable on serial CT and bone scan imaging, but his PSA was starting to rise, and the medical oncologist was concerned that he may need to switch him onto chemotherapy. A PSMA PET CT was organized, and that showed two areas of oligoprogression. So there was, in the upper right panel here, an area of increased uptake in the pubic bone, and in the lower right, an area of increased uptake in the sacrum. That suggested these were potentially two isolated areas of prostate cancer that were escaping control with the hormone therapy, his existing hormone therapy. So we targeted these areas with stereotactic radiotherapy with the hope that we could return his disease control on his current systemic therapy and avoid the need to move to the next line of treatment. So I hope through these examples I've shown you ways in which PSMA PET CT can be integrated into the management of men with limited metastatic disease, and I thank you for your time.